Hello, everyone. I'm Carol Devon Stryker, Project Guide with the Greenhouse Project. I'm really excited to work with our greenhouse sponsor, Cine, to bring you today's webinar, A Person-Centered Approach to Urinary Incontinence, featuring Dr. Rosemary Laird. Dr. Laird comes to us with some impressive credentials, including being the Clinical Associate Professor at the Department of Geriatrics at Florida State University School of Medicine. She's a graduate of Georgetown University's School of Medicine, and she specializes in geriatrics and caring for people living with Alzheimer's disease. Her experience includes 20 years as a medical director for clinics focusing on memory support. She was appointed by the Florida governor, to be on the state Alzheimer's disease advisory committee, and she was American Geriatric Society's Geriatrician of the Year in 2013. So all of that, and she's a passionate advocate and an author on supporting elders and family members. So just before we get started, there's a few logistics. All the webinar attendees, except for the presenters, will be muted to minimize the possibility of background noise. Yet we love hearing from you and really encourage you to use the chat box or the Q&A to ask questions or make comments at any time. You'll receive a link to the webinar recording and some handouts about 24 hours after the webinar ends. And if you're interested in receiving 0.75 nursing contact hours for this session, you'll need to attend the entire webinar and complete the evaluation. The link to that evaluation will be provided at the conclusion of today's session. And I want to mention that Dr. Laird does not have any conflicts of interest. So I'm pleased to introduce you to Dr. Rosemary Laird, who's going to give some great information to us. Dr. Laird, it's all yours.
Thanks, Carol, and hello to everyone. I really appreciate this invitation and opportunity. After having learned about the Greenhouse Project and their focus and the work they're doing, my interest in promoting person-centered care across all the different types of illnesses that give our elders challenges, this really fit very well together. So today we're going to be focusing on how aging impacts urinary incontinence, chronic urinary incontinence in particular. And we've divided things up today into three distinct sections. We're going to cover first some basics, what does aging do to urinary incontinence? We're then going to talk about some strategies you can use for assessment. There can be some tricky aspects to really figuring out what's happening to someone who's got some difficulty with urinary incontinence. And then finally, we'll bring it all home and wrap it up together with using some really good person-centered or patient-centered principles of care that have us learning from our patients through some cases. So I hope that's something that's going to be useful to all of you. So thank you, Janet, for forwarding our slides. And I think you can go ahead and move on to the next. We are going to start with the basics. And with respect to that, as we learn about the basics here, what we really need to understand are that the aging effects on the urinary tract are multiple, and they really do significantly affect, why someone would be susceptible to chronic urinary incontinence. And in addition to that, so as we all get older, we've got age-related problems happening, right? And changes to our body. We also have other medical conditions that can come up. And so for those of us who want to care for elders, we've got to understand both aspects of that. So let's go ahead and move into that important topic. So first things first. So Janet, the next slide will kick us off talking a bit about this idea, this understanding of urinary incontinence, not as just an embarrassment or an eventuality of aging. Please sort of first take home message is that it is not a normal part of aging. Now, it's prevalent, and you can see here I've got at least 50% in some studies, and other groups of elders, you'll have far higher percentages of people who've been affected by urinary incontinence at one time or another. So you might look at that and say, well, it's just about everybody. And that may be the case, but it's not only because of the way the body changes. There often are many, many other things happening that are creating the urinary incontinence. Therefore, that leaves us responsible as clinicians to help do whatever we can to mitigate and help someone through this symptom. And you can see by what I've chosen to highlight here on the slide that the downstream effects, if you will, pun intended, right? The effects of urinary incontinence go far beyond the effects of the urinary dribbling and the local effects on skin and wounds, what we all think about, which is very important, obviously. But that isolation, the emotional symptoms, their overall decreased quality of life, all of that is part and parcel of this symptom. In addition, you can have subsequent medical problems that come from this problem: increased falling, increased risk of fractures, and overall decreased functional ability can come right along with urinary incontinence. So we don't want to just say, you're 80, you're 90, this is what's going to happen. No, let's not do that. Let's pay more attention and have a thoughtful strategy and understand that we need to be looking for certain aspects of this individual's either aging related change and or medical conditions, medications we'll touch on too, that can impact and be contributing to their urinary incontinence. Janet, the next slide, please. Okay, pop quiz. Now you're lucky we're in a webinar. I can't see you, so I can't pick on somebody, but you know, here's the pop quiz, just to get us all thinking together. What's the most common chronic condition among older adults in long-term care? Now you're probably thinking, well, she made that easy because she put it on top. It is urinary incontinence. But the reason I wrote this question the way I did is because I put depression, hypertension, and diabetes up there. Yeah, they're very common too. But think about this, urinary incontinence beats them. And we all pay a lot of attention. Think about your day-to-day care of patients. You do a lot for hypertension. You do a lot for diabetes. Hopefully we're doing a lot for depression, but just think about that. Contrast that to what we do for urinary incontinence. So we've got some work to do. Next slide, please. Okay, finally, I'll get to the point about what happens to an aging urinary tract. The first thing I like to always point out, actually, take a look at the picture. We tend to focus, as this picture does, on the elements of the urinary tract. Fair enough. There are changes to the kidney, the urethra, the bladder, in men, the prostate, in women, the pelvic floor. There are changes there that you can see listed that generally can relate to increasing urinary incontinence. But one of the things that's not listed and generally doesn't show up all the time, look at the first item I've listed on the slide, cognition. Keep that in mind. Cognitive changes, as well as other neurologic changes in the decrease in the neural activity, either from thinking or the way the body's nervous system responds. Can be an age-related change that can impact this problem. So that's something that sometimes gets missed that I want you now to be keeping your eye out for. In addition, let's see, other things I didn't mention, the bladder itself has a decreased capacity. So the teeny tiny bladder syndrome that we all sort of talk about, that does actually end up happening and is something that can be a big problem. The rectum I didn't mention, but in both men and women, of course, that's another area of the body that as we age can become less toned and therefore contribute to urinary incontinence. And then the sort of classic problem that creates a lot of the trouble in women is the changes in the lining of the vagina, the urethra, and the ureter. And then in men, it's the changes in the prostate and that contribute to that. Next slide, Janet. So what we're going to talk now is, I've just shown you how aging alone gives you those are a lot of different changes to the structure, the infrastructure of how we are able to maintain control of our urine. On top of that, you have to understand that there's medical conditions as well that can impact urinary control, right? So the bladder itself can be affected by, from a physical standpoint, by obesity. It can be affected by constipation. Actually, kind of the constipated bowel can kind of poke on the bladder and cause trouble, leaving it further decreased in its capacity. A chronic cough might be able to trigger someone to have high intra-abdominal pressure that leads to urinary incontinence. The neurologic problems you're probably a little bit more familiar with: stroke, dementia, we just talked about that, right? Multiple sclerosis, diabetes with its neuropathic problems, spinal cord injury, of course, and I mentioned stroke. I put cerebral vascular disease there as well, just to remind myself that even people without stroke that we know about can be having problems neurologically. The kidney itself, interestingly, unless the kidney is really failing and not creating urine, it does sort of withstand and doesn't contribute to too much problem here. But I've listed the things that can make the kidney not function well. And if the kidney is not functioning well, you're actually going to have decreased production. And decreased production actually is going to end up causing trouble with control as well. And musculoskeletal conditions, don't forget this. Someone with arthritic problems, either pain or unsteady gait, those are common contributors to urinary incontinence on the functional side of things. Okay, next slide, please. So I've now just referred to the sort of medical conditions. What other things do I want you to kind of keep in mind? You've got a lot to keep in mind already, but things like dehydration, believe it or not, can actually contribute. Kind of like I was talking about decreased kidney function, that can contribute when you don't have enough normal flow going on. Toileting habits can cause a problem. Too frequent voids, that can be difficult sometimes with our cognitively impaired individuals. Direct bladder irritants, things like carbonation, caffeine, that can be a problem. And then the other area that I end up talking about a lot, functional ability. So either your dexterity to undo zippers and buttons, or your gait speed and your ability to get to the bathroom, perhaps in a rush, because your neurologic connections are not so great. So you get very little warning. So you can see right there, this combination of my aging neurons are leading to poorly timed signals. And then I'm someone with arthritis and very difficult dexterity in my hands. Those, and maybe I also have some high blood pressure and a diuretic. That's how, from a patient-centered way, knowing all these things, you can zero in on what your patient's issues might be around the problem of urinary incontinence. Okay, next slide. So this gets us into kind of just the basics of the types of urinary incontinence. I'm sure quite familiar. So we basically, that bladder I said that was getting maybe too small, it can be overactive and not really be as coordinated as, oh, I should stay closed, or, oh, it's time to open up. It can get poorly signaled, really. So that's number one there. Number two is functional, and you're going to hear me refer to that a lot. That's the people who either from their cognitive function or physical function are having some impediment to getting to a restroom at the right time. The number three is stress incontinence. So that picture is supposed to be someone coughing. You heard me reference chronic cough, but any sort of increased abdominal pressure can create that kind of stress urinary incontinence. Number four is a combination of any of the other types. And number five is overflow. And that's where the bladder doesn't have the ability to contract when it should. So it allows itself to get too full. It's lost its ability to contract properly, and it can actually get too full. And at a certain point, you just don't have enough capacity in that bladder anymore, and it'll start to overflow its sphincters. So those are kind of the basics. What I want to do now is show you the next slide that to me is really important. And if you're going to sort of help shift anything you do from a urinary incontinence standpoint, I'd like to vote for this being one of them. And that is, I just went over kind of the basics of the types of urinary incontinence. And I did that so that as we start to think about, well, what does my patient have? I want you to have a construct in your head of, okay, these are the types. Now, I want to point out that in addition to what I just talked about, look on the far right of this slide, you'll see the words, the types we just reviewed: overactive, functional, stress, and overflow. And then we also covered mixed. But now look to the far left. I added the word multifactorial. And that actually turns out to be what a group of individuals like yourselves who are interested and spend most of your time taking care of older adults or chronically ill individuals, that's actually where most of your attention needs to be spent. Now, you can see multifactorial doesn't tell you what's happening. So I understand that, but remembering that multifactorial is the likely answer will remind you to look for more than one cause. When you start looking for more than one cause, you start finding a range of things to address. And you'll see as we talk about assessment, but actually more so about how to help people in our case conferences, urinary incontinence is one of those conditions where you've got to look for multiple things. It's rarely one answer if it's a chronic urinary incontinence. I wish it was simple and just one thing, but it's not. But that's where, you know, the skill of being a clinician becomes so important. So this slide, keeping that in mind, remembering you're looking for multifactorial. And the next slide is just meant to give some research behind what I just said. And so this was a group of patients from a range of different long-term care facilities in this particular community. And what they've done, as you can see, the lighter blue is the situation when there's more than one type of urinary incontinence. The dark blue is when there's only the one type of urinary incontinence that is labeled on that category. You can see that the big bar representing more people, so the y-axis is number of people with this condition. Mixed is more prevalent than one time alone for every single type of the urinary incontinence. So again, this is our world, these are our people, and this is the kind of urinary incontinence we've got to be ready and aware to go find. So those are the basics. What we're going to do at this point is stop and take any questions, and then we're going to move on from there. So I think Carol's going to pop back on here and see if anybody has any questions for us.
Yes, so it sounds like urinary incontinence is prevalent in about half of our populations, and that's impacted by lots of comorbidities, and there's lots of different reasons that elders experience urinary incontinence. So we've got a large group of people on the webinar. Does anybody have questions or comments to share? Oh, here comes one. So what is the typical age range for these?
So typically the data that I'm looking at is usually looking at the 65 and up. And whenever I show you some data from, like the example of the slide I just showed, showing research about long-term care, that long-term care research tends to actually skew even older. So it's usually in the mid 70s. And I think I'm looking at it now, age 78 was kind of their median there. So this is definitely 65 and up, maybe even skewed a little bit older.
Okay, another question is, you said 50% prevalence in long-term care. What's the prevalence in general for the 65 and older population?
And I'm going to want my Seni friends to correct me if I'm wrong, but in the general population of a community dwelling, not living in long-term care, I think it's about 20% that have at some point in time experienced incontinence. So it still has a relatively high prevalence. So that's not someone who necessarily has it all the time, but this is an episodic illness for many people. So,
Right. And another question that came in, has there been a study that tracks how many persons living with dementia became incontinent after moving into a long-term care community when they weren't before?
No, there probably is some expert watching us right now who knows that answer. And it's a sad question, isn't it? Now, but in fairness, dementia as a chronic illness by its nature will have from that disease, if someone survives long enough into the later stages, the disease itself will bring urinary incontinence, not from any sort of effect of your external environment. So I'm not sure what, depending on the contextual aspect of that question, I just want to point that out too, that, dementia itself can create that. But I think to potentially the questioner's point of view, institutional care, large institutional care, does unfortunately create some challenges with this particular symptom. And you'll see when we talk in a few minutes about assessment, there isn't, I wish there was like a simple blood test or, a little x-ray to help figure out this diagnosis and say, oh, this is the treatment. There isn't. These are relatively complex. I just showed you how complex the causation can be. So the assessment is similarly complex and the therapy is similarly complex. One reason, having groups like yours focus on this and other groups that care about person-centered care is because this is one of the conditions that demands person-centered care. You really have to understand what's happening to that person to be able to, with this symptom in a very comprehensive way, to be able to help them. And yet I hope the motivation is high to do it, because the statistics are quite good that while you may not cure someone of urinary incontinence, you can reduce the effects. You can restore some dignity. You can leave them more active, more willing to go out if they're otherwise capable. So, there's a lot of positives that can come from paying attention to this very common symptom.
Excellent. All right, we have some more questions in the Q&A, yet those questions seem to go better with our assessment topic and our case study topic as well. So we'll just take a minute and we will transition